of you. So I will start with my presentation. So triggering in ART, the different triggering options and patient individualization we'll see one by one. So what is actually triggering and what happens in unstimulated cycle we'll see. Whenever there is LH surge, resumption of meiosis 1 occurs, and then the oocyte progresses to metaphase 2, and then we are getting a mature oocyte. So if at all we can say that reasonable accurate time of ovulation may be post 10 to 12 hours after LH peak, or 24 to 36 hours post estrogen peak, or maybe onset of LH surge post that 34 to 36 hours. So the threshold of LH surge should be maintained minimum for 14 to 27 hours in order for full maturation of oocyte to occur. So in stimulated cycles, like what is constituting a trigger? So we are exploiting the structural homology between LH and HCG if we are using HCG, and we are taking standard as 36 hours length of time from the initiation of LH surge and thinking that that is the optimum time when it will ovulate. So the triggering options may be urinary or recombinant HCG, GnRH agonist trigger or dual trigger. Also recombinant LH and kispeptin triggers are also there, but those are not available for clinical use. So endogenous trigger may be LH, exogenous may be HCG, recombinant LH, GnRH or kispeptin, out of which the present triggers are only HCG and GnRH agonist. So HCG trigger, we can say that there is urinary HCG trigger which is most accessible, but the problem is that the source is variable and batch to batch variation is seen. Recombinant HCG is purified by immunoaffinity chromatography, and actually it can be used in any type of IVF protocol like long GnRH agonist, microflora GnRH agonist. So if we see comparison between urinary HCG trigger and recombinant HCG trigger, at present there is no significant difference in both triggers. Ongoing pregnancy and live birth rates are similar and rates of OHSS are also similar. So what is associated with risk with HCG trigger? It is surrogate LH surge, and its prolonged luteotropic effect leads to development of OHSS. So this is associated risk of HCG trigger. It can be early onset, which may be between 3 to 7 days post HCG, or maybe late onset, which may be 12 to 17 days after HCG. So if we see here that HCG is very dreadful if OHSS is severe, and here you can see that there are 3 maternal deaths out of 1 lakh just due to the complication of OHSS. So that also causes loss of control over controlled ovarian stimulation. So elimination of severe OHSS can be withholding the HCG trigger or cycle cancellation. But what is happening with cycle cancellation? That patient's frustration is increasing, money is consumed. So the aim will be to have OHSS free clinic. And for that OHSS free clinic, we can use as GnRH agonist trigger, which may be better. So how does this GnRH trigger act, and in which cycles it can be used? It can be used in antagonist protocol, mild or minimal stimulation protocol, or modified natural cycle protocol. But we should know that when GnRH agonist trigger will not respond, first is GnRH agonist protocol or profoundly suppressed LH, in which the patient is kept on OC pills, or there is hypothalamic dysfunction. So LH surge may natural cycle whereas GnRH agonist triggering. Here you can see that for natural cycle there is long ascending limb plateau and again a long descending limb. But for a GnRH agonist trigger, it is short ascending limb and long descending limb. So the half-life or the duration of GnRH agonist trigger is limited, and that is the crux where it is actually curbing the complications of HCG trigger. So with GnRH agonist trigger, risk of OHSS is eliminated due to short half-life, and also HCG exposure is not there. So GnRH agonist trigger may be favored in oocyte donor patient, high responder patient, normal responder patient, or in patients undergoing fertility preservation. So it is more physiological, eliminates or reduces risk of OHSS, but luteal phase support is required. So drawback of GnRH agonist trigger is that luteal phase deficiency, for which rescue we can give a small bolus of HCG or intense progesterone in estradiol support we can give, but is found to be appropriate in oocyte donors, pre-sol cycles or fertility preservation. Also, that may be the best OHSS free clinic in which we can do segmentation of IVF, in which we can use antagonist stimulation, agonist trigger, vitrification, and FET. So, segmentation of procedures can be done. Now, the newer concept is dual trigger. So, in which we can use a low dose of HCG and a GnRH agonist trigger. So, it rescues luteal phase and it is having comparable live birth rate with higher doses of HCG. So, protocols for dual trigger, the doses are there. Mostly we use agonist trigger of leuprolide, or triptorelin, but others are not used even if it is said. And again, we can use HCG. So HCG low dose bolus causes leukotropic effect, so due to which progesterone or corpus luteum is maintained, and supplemental HCG even in low dose can still lead to early onset OHSS, which we should be aware of. So these are the combinations or different modes in which we can use dual trigger. Here we are seeing that with GnRH agonist trigger, it is more physiological, so higher number of mature oocytes are seen. The second cause is that concurrent release of pituitary FSH is there, which again yields into less number of atretic follicles post trigger. So here you can see that dual trigger significantly improves live birth rate for women with diminished ovarian reserve, and also it improves oocyte maturity and fertilization proportion. So GnRH agonist and HCG trigger can be used as a new strategy for follicular maturation. We can use boluses of small at 1500 or 5000 to 10,000. Our aim is to improve oocyte quality and embryo quality and consequently IVF cycle outcome. So, double trigger can be of very useful in patients with recurrent empty follicular syndrome, abnormal final follicular maturation, less number of oocytes are retrieved or less number of mature oocytes are retrieved. So in poor responders, if we see there is problem with GnRH agonist trigger because of its short duration of action, which can lead to immature follicles or decrease proportion of mature oocytes. So dual trigger is mostly preferred in poor responder patient. To summarize, HCD trigger can be used in poor or normal responders, but high risk of OHSS should be seen. GnRH agonist trigger, lesser risk of OHSS, but higher early pregnancy loss. The newer is the dual trigger or double trigger, which is having improved luteal phase and outcome, but still we should be aware of OHSS. So further role of dual trigger should be studied, and one more principle that no harm should be done in this process of experimenting with dual trigger. So our next topic for today's presentation is exploring the luteal phase, pathological insights and assistance. So here we see when a thing ceases to be subject of controversy, it ceases to be subject of interest. So sometimes we feel that while luteal phase defect is so much prevalent, why we should give progesterone? Is it marketing strategy or is it really required? So there should be some subject of controversy. Then with the interest, we can go into insights and depth of the subject and understand like if it is really required or not on evidence-based medicine. So why we are seeing regarding luteal phase defect? Because in infertile population, 3.5 to 14% is incidence. In unexplained infertility is 15 to 20%. And also in recurrent pregnancy loss, it can rise to 30 to 40%. So what is actually happening after ovulation is that LDL cholesterol or lipoprotein substrate is converted into progesterone, and due to this LH surge and ovulation, basement membrane is broken down and angiogenesis happens, and this there is formation of corpus luteum, and hence this corpus luteum works by many mechanisms. The first is formation, which which is by surge of LH at ovulation, in which terminally differentiated uh, uh, cells are there for luteinization, which can't grow further. They get hypertrophied. Lipid droplets are then deposited in their cytoplasm and give them golden yellow color. The second is maintenance, which is done by LH. And the third is maternal recognition of pregnancy, in which implanting blastocyst secretes HCG, and there is uteroplacental shift around 8 to 9 weeks of gestation. So role of LH in luteal phase is very crucial, as we can see that it is responsible for steroidogenic activity, upregulation of growth factors, cytokines, and stimulation of LH receptors. So what happens actually, there are two cells. One is granular lutein cells, which are not responsive to LH or HCG, and in second half they are responsive to LH or HCG. These are thicker lutein cells. So in normal menstrual cycle, if we see, there is LH surge followed by progesterone secretion from corpus luteum. So in natural pregnancies there, then this progesterone will keep on continuing. HCG will slowly come from implanting blastocyst, and in this way, LH surge will drop down over the time. So in HCG trigger, here you are seeing that there is some dotted line yellow where HCG will be given artificially, and post subsidence, then the blastocyst may take over. And here you can see that progesterone also peaks, and after that it goes into maintenance phase. So what happens with agonist trigger is more important. Here you are seeing that with agonist trigger, actually there is LH which is secreted, and then progesterone is also secreted for some amount of time, and there is some kind of uteroplacental shift deficiency in which HCG takes over the function, and this deficit is responsible for non-implantation or for abortion, which we are taking care of. So that's why we are discussing luteal support in IVF. So the rationale is that sometimes if this natural uteroplacental shift doesn't happen, there is luteal phase defect. But sometimes there is suppression of endogenous LH hormone, which again leads to persistent pituitary suppression of GnRH agonist, so the pregnancy is not achieved. Or sometimes supraphysiological levels, which are there by GnRH agonist trigger, causes asynchrony between embryo and uterine endometrium, and that causes decreased pregnancy rate in IVF cycles. Or sometimes there is abrupt decrease in serum concentrations of estrogen and progesterone, or sometimes during pickup we are aspirating granulosa cells, so due to which the luteal luteinization or progesterone secretion is not optimum to save that pregnancy. Or sometimes multiple corpus lutea are there secreting supraphysiologic or more progesterone, which causes negative feedback on progesterone and decreases LH levels. So these may be another under the belt problems which we might be seeing. So it's better to give luteal phase support, so that if these problems, if the patient is facing, may be taken care of. So here you are seeing that in upper panel we have given exogenous progesterone, and with that we are giving IM injections of progesterone. And here we are seeing the pattern in which there is no deficiency because we are starting from the first, it is a frozen embryo transfer cycle. But suppose in second graph, if you are seeing in which we are actually giving endogenous progesterone in pulsatile way, in which we are seeing that the progesterone is maintained, but there is gap between HCG secretion and progesterone which is coming down, and that gap should be administered. Otherwise, progesterone deficient state may cause abortion or may lead to untoward outcomes or bad obstetric history. And in the lowermost, if you are seeing, sometimes this supraphysiological or the high hormone state causes negative feedback and decreases LH, and due to which this luteal phase deficiency time length may be more, and that may surely cause no pregnancy to the patient or no possible good outcomes to the patient, which we should take care of. So here you can see that low luteal progesterone levels are associated with lower ongoing pregnancy and live birth rates. So that was actually proposed. So here are some studies. So luteal phase in fresh ART cycles, progesterone levels at different stage during IVF, if you can see that low live birth rate was reduced if the progesterone levels are less than 4.77, or on the day of embryo transfer live birth rate was reduced if the progesterone levels are less than 15. So minimum progesterone level should be maintained for ongoing pregnancy or live birth rate for better obstetric outcomes. So here you can see in fresh and embryo transferred, it is double A sword, in which if progesterone also we are giving with HCG may cause supraphysiological levels and decrease LH. And if you are not supplementing, then the other problem is that the issue is that there may be luteal phase defect. So in that comparison, frozen embryo transfers are better, in which all modalities of progesterone HCG we can give in order to actually increase the live birth rate or pregnancy rate. So which route? Actually, all studies are there, many studies are there. There is no difference in the route of administration, but minimum progesterone level should be maintained and that should be taken care of. So here you can see that with route, yes, IM was having better absorption over vaginal progesterone, but still if you are giving multiple combinations of progesterone, there is no significant role. Then we can see here that how much progesterone is enough. If you are seeing different routes, then you can take photo of this slide so that this much progesterone, if you are supporting as luteal phase support, may be enough. So which situations are requiring higher dose of progesterone is endometriosis and PCOS. Surely there is impact of BMI on progesterone support. So if the overweight patient or obese patient is there, then there should be higher luteal phase support. Also, timing of luteal phase support according to the cycles is mentioned in the slide. You can go through that in detail. And also post oocyte retrieval, immediately starting of luteal phase support may create a difference. But if at all we are not giving for fresh embryo transfer, here it is written that significantly lower pregnancy rate can be seen. Also, where it should be started and when it should be stopped. As per now, recent consensus, till 11 to 12 weeks of gestation, until there is uteroplacental shift, then until that time we should always supplement with progesterone as a luteal phase defect. So here you are seeing that we should actually supplement till 10 to 12 weeks of pregnancy. And here dihydrogesterone or micronized vaginal progesterone, actually dihydrogesterone was more effective in bioavailability or pharmacokinetics, but still the outcomes were not that much statistically significant. Estradiol supplementation during early phases is also showing no significant difference, but HCG administration is showing difference because of the luteotropic effect of HCG, which is secreting more progesterone endogenously, but there are higher risk of OHSS also. Sometimes also it has been proposed that we can use GnRH agonists during transfer so that that may cause luteal phase support. So it has been proposed that we can use triptorelin point 0.1 or point 0.2 on the day of transfer, so that that may have a positive effect on the pregnancy outcomes. So here you can see that many RCTs are there, and GnRH agonists significantly increase live birth or ongoing pregnancy rate. But GnRH agonist also was not increasing rates of OHSS. So luteal phase support in FET cycles may be post-embryo transfer. Then we can use multiple options. Our aim is that the progesterone level should be more than 40 as a luteal phase support. So that cutoff you might take, but more than 15 is also enough. But ideally it should be more than 40. So rationale for combination is that there are three ways in which we can act. The oral can have first pass metabolism, so the absorption may not be guaranteed. IM has peak and trough, so may not be guaranteed way. Or per vaginal also there might be absorption differences. So giving combinations may actually be better to maintain these progesterone levels. So we normally suggest patient that by multiple routes they may take progesterone, so the progesterone levels are maintained, taking into account the physiological variations of each patient's body. So can we give too much progesterone, more is better or not, was the question. And there were many studies in which it was seen that higher levels of progesterone were never impacting live birth rate in frozen embryo transfer, and with more progesterone it is not causing no harm to the patient. So individualized luteal phase support should be seen based on the previous history, characteristics, BMI, age, the cycles, and that way we can plan. So GnRH analog, as I have already discussed, we can use that during transfer, and in frozen embryo transfer it is must recommended. So in our protocol for fresh transfer, we use HCG trigger. We can use micronized progesterone 400 mg BD, oral dihydrogesterone and HCG trigger, or dual trigger plus estrogen 2 mg BD, taper and stop at 10 to 12 weeks. For FET protocol, we are using vaginal progesterone, oral dihydrogesterone, and injection progesterone every third day. So, what are the directions for future research? That what is the immune system response? Like if it is decreasing immunorejection or not. Assess risk of harm at high serum progesterone levels, which needs a broader approach. Action of different progesterone receptors. Action of different progesterone formulations. Variation in pharmacokinetics. And lastly, which is important, whether progesterone resistance affects the success of implantation. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. So, with this sentence, still the research is going on. We can open eyes to newer combination, newer ways, newer formulations, and accept and practice what may be the best in the interest of the patient and to have a good live birth rate or clinical pregnancy rate. So still the process is ongoing, and maybe you might have got some insights that how luteal phase acts or what should be recommended. Thank you for your patient listening. Any questions may be addressed in the question box.
Thank you. Thank you so much. Thank you so much, Dr. Indraneel, for your for delivering this wonderful session and your best practices with us. So we will go forward with the question and answer session. If anyone has any question, please ask. So there is a one question. When to do progesterone level?
If it's natural cycle, then we should do on day 21st. And if the levels are below 3, we can suspect luteal phase defect in this patient and we should administer. for transfer patients, just before transfer, maybe if you're doing blastocyst transfer, just previous to that transfer, we can do progesterone levels. Normally, the recommendation is more than 15, but more than 40 will be enough.
Thank you, Dr. Indraneel. Anyone has any questions? I think Dr. Indraneel, no one yeah, having any question. So thank you so much. Thank you so much everyone for joining the session today. And thank you, Dr. Indraneel.